Acute myocardial infarction. Septemius A. Panzacola or N. MD. Acute myocardial infarction. End result of luminal narrowing of coronary arteries. Reduction of blood supply. Reducting of O2 supply. Epidemiology. WHO estimated that in 2002, 12.6% of deaths worldwide. Ischemic heart disease is the leading cause of death in developed countries. In the U.S., approximately 1.5 million cases of MI occur each year. Risk factors: older age, male gender, cigarette smoking. Hypercholesterolemia, more accurately hyperlipoproteinemia, especially high low-density lipoprotein and low high-density lipoprotein. Diabetes. High blood pressure. Obesity. Pathophysiology result of atherosclerosis. Disease affecting arterial blood vessels. It is a chronic inflammatory response in the walls of arteries. Deposition of lipoproteins, plasma proteins that carry cholesterol and triglycerides. Formation of multiple plaques within the arteries. Heart attack. Atherogenesis, development of fatty streaks. LDL in blood plasma invades the endothelium and becomes oxidized. Free radicals in the endothelium. Inflammation response. Monocytes, a type of white blood cell, enter the artery wall from the bloodstream, with platelets adhering to the area of insult. CAM1. Monocytes differentiate into macrophages, which ingest oxidized LDL, slowly turning into large foam cells. Atherogenesis. Foam cells eventually die, and further propagate the inflammatory process. Smooth muscle proliferation and migration from tunica media to intima. Formation of a fibrous capsule covering the fatty streak. Atherogenesis, calcification and lipids. Intracellular microcalcifications form within vascular smooth muscle. Leads to extracellular calcium deposits. Cholesterol is delivered into the vessel wall by cholesterol-containing low-density lipoprotein, LDL, particles. To attract and stimulate macrophages, the cholesterol must be released from the LDL particles and oxidized, a key step in the ongoing inflammatory process. The foam cells and platelets encourage the migration and proliferation of smooth muscle cells. These capped fatty deposits, now called atheromas, produce enzymes that cause the artery to enlarge over time. Atherogenesis. Leukocytes such as monocytes or basophils begin to attack the endothelium. Inflammation leads to formation of atheromatous plaques in the arterial intima. Excess fat, collagen, and elastin. Initially, wall thickening. Stenosis is often the result of repeated plaque rupture and healing responses. Rupture and stenosis tissue fragments are exposed and released. Very clot promoting, containing collagen and tissue factor. Activate platelets and activate the system of coagulation. Formation of a thrombus, arterial wall. Ruptured atheroma. Atheromatous plaque, 3 distinct components. Atheroma is the nodular accumulation of a soft, flaky, yellowish material at the center of large plaques. Cholesterol crystals. Calcification at the outer base of older/more advanced lesions. Complication: plaque ruptures and stenosis, narrowing of the artery. Formation of a thrombus. Aneurysm. Acute myocardial infarction. Major pathological types. Transmural infarct. Full thickness. Endocardium to epicardium. Q-wave infarct. Subendocardial infarct. Involves the subendocardium, the intramural myocardium or both. Non-Q wave infarct. Diagnosis: history, chest pain, location, substernal. Radiation, left arm or left shoulder. Character, crushing, constricting, heaviness. Intensity, severe. Duration, more than 20 to 30 minutes. No relief from nitroglycerine. Rough diagram of pain zones in myocardial infarction. Dark red equals most typical area, light red equals other possible areas. View of the chest. Accompanying symptoms: diaphoresis, profound weakness, sense of impending doom, anxiety, vagal symptoms, N and V, diarrhea, abdominal pain. The most common symptoms of ME in women include shortness of breath, weakness, and fatigue. Approximately 1/4 of all myocardial infarctions are silent. Elderly. Diabetes mellitus. Differences in pain threshold, autonomic neuropathy, and psychological factors. After heart transplantation. Physical examination, general appearance, vital signs. Anxious, restless, diaphoretic, cold, clammy skin. Vital signs: BP, normal, hypotensive CHF, vasovagal reaction. HR, slow or fast, regular/irregular rhythm. Temp, maybe febrile. RR, tachypneic. Heart-lungs dyskinetic, cardiac impulse S1 muffled, S4 usually present. S3, heart failure. Systolic murmur. Pericardial rub. Lungs. Rails, CHF. ECG findings: transmural infarction, hyperacute T waves, ST elevation. Pathologic Q wave. Loss of R wave. Subendocardial infarction. ST segment depression. Inverted T waves. ECG ST segment elevations and STEMIs. Typically due to complete occlusion of a coronary artery. STEMIs. Typically a sudden narrowing of a coronary artery with preserved, but diminished, flow to the distal myocardium. Anticoagulation and antiplatelet agents prevent the narrowed artery from occluding. Exercise stress test. Determine the amount of stress that your heart can manage. Before developing either an abnormal rhythm or evidence of ischemia. Exercise stress test. A physician may recommend an exercise stress test for various reasons. Diagnose coronary artery disease. Diagnose a possible heart-related cause of symptoms. To determine a safe level of exercise. To check the effectiveness of procedures done. To predict risk of dangerous heart-related conditions such as a heart attack. Effectiveness of medications to control angina and ischemia. Types of stress tests: dobutamine or adenosine stress test. Used in people who are unable to exercise. Heart respond as if the person were exercising. No exercise is required. Stress echocardiogram. An echocardiogram, often called echo, is a graphic outline of the heart's movement. Accurately visualize the motion of the heart's walls and pumping action when the heart is stressed. Nuclear stress test. Determine which parts of the heart are healthy and function normally and which are not. Radioactive substance is injected into the patient. These pictures are done both at rest and after exercise. A less than normal amount of thallium will be seen in those areas of the heart that have a decreased blood supply. Cardiac enzymes, proteins releases by necrotic myocardial muscle cells. SCIT. Rise, 8 to 12 hours. Peak, 18 to 36 hours. Normal, 3 to 4 days. Elevated, hepatic diseases, skeletal muscle disorders, pulmonary embolism. Holter monitoring. Continuous monitoring of the electrical activity of a patient's heart muscle, electrocardiography, for 24 hours. Special portable device called a Holter monitor. LDH CPK rise, 24 to 48 hours peak, 3 to 6 days. Elevated, hemolysis, liver and renal disorders, pulmonary embolism. CPK. Creatine phosphokinase isoenzymes. Fraction, skeletal muscle MB fraction, heart muscle BB fraction, brain. Rise, 6 to 8 hours. Peak, 24 hours. Normal, 3 to 4 days. Elevated, alcohol intoxication, trauma, intramuscular injection. MB fraction. Section rises and returns to normal sooner than total CK. Section rises in 3 to 4 hours. Section returns to normal in 2 days. Troponin I, CTNI, or T, CTNT, are the forms frequently assessed. Rises 2 to 6 hours after injury. Peaks in 12 to 16 hours. TNI stays elevated for 5 to 10 days. TNT for 5 to 14 days. Time sequence after myocardial infarction. Myoglobin. Found in striated muscle. Damage to skeletal or cardiac muscle releases myoglobin into circulation. Time sequence after myocardial infarction. Section rises fast, 2 hours, after myocardial infarction. Section peaks at 6 to 8 hours. Section returns to normal in 20 to 36 hours. Have false positives with skeletal muscle injury and renal failure. Other laboratory findings: leukocytosis, neutrophilia, elevated ESR, radiologic findings, chest X-ray, normal, cardiomegaly, signs of CHF. Ancillary procedures: myocardial perfusion scan, technetium pyrophosphate scan. Confirm the diagnosis. Isotope is taken up by damaged cells. Plus 36 hours, remain for 6 to 10 days. ECG and enzymes not conclusive. Hemodynamic monitoring. Swan-Ganz catheterization. Right side of the heart. Pulmonary artery pressure. Pulmonary artery occlusive pressure. Right atrial pressure. Cardiac output. Coronary angiogram allows to visualize narrowings or obstructions. Therapeutic measures can follow immediately. Kill-up classification. Used in individuals with an acute myocardial infarction. To risk stratify. Individuals with a low kill-up class are less likely to die within the first 30. The kill-up classification. Kill-up class I includes individuals with no clinical signs of heart failure. Mortality rate equals 6%. Kill-up class II includes individuals with rales in the lungs, an S3 gallop, and elevated jugular venous pressure. Mortality rate equals 17%. Kill-up class III describes individuals with frank pulmonary edema. Mortality rate equals 38%. Kill-up class IV describes individuals in cardiogenic shock. Mortality rate equals 81%. Treatment goal: pain relief, reduction of myocardial oxygen consumption. Prevention and treatment of complications. Monitoring vital signs. Admit to the CCU. Activity. Day 1, bed rest, if stable. Day 2 to 3, bed rest, but patient may be allowed to sit on a chair for 15 to 20 minutes. Early mobilization is recommended for uncomplicated AMI. Monitoring vital signs. First 6 hours Q30 60 minutes. Next 24 hours Q2 hours. Thereafter Q4 hours. Diet. NPO, first 24 hours. If stable low salt, low cholesterol diet, For fluids laboratory studies D5W2KVO. If unable to take food/fluid per ORM, 1000 milliliters/8 hours. K supplement. Laboratory studies. ECG daily for 3 days. Enzymes. Electrolytes. Bun/creatinine. FBS. CXR daily for 3 days. Medications: nasal oxygenation for the first 24 hours, relief of pain. Morphine SO4, 2 to 5 mg/4 dose. Potent analgesic. Peripheral venous vasodilation. Pulmonary venous distension. Inferior wall may increase vagal discharge. Pethidine HCl. Tranquilizers, laxative to decrease anxiety. Diazepam, 5 to 10 mg per 4/ORM. Laxative. To prevent straining during defecation. Lactulose, HS, drugs to limit infarct size. Beta blockers. Hyperdynamic states, HPN without evidence of heart failure. Reduce myocardial oxygen consumption by decreasing cardiac index, stroke index, heart rate, blood pressure. X, propranolol, metoprolol. Nitrates act by augmenting perfusion at the border of ischemic zone. Dilating collaterals. Reducing myocardial O2 demand. Lowering preload. Lowering afterload. X, 4-nitroglycerine, sublingual nitroglycerine, oral/transdermal nitroglycerine. ACE inhibitors reduce mortality rates after ME. Administer ACE inhibitors as soon as possible. ACE inhibitors have the greatest benefit in patients with ventricular dysfunction. Continue ACE inhibitors indefinitely after ME. Angiotensin receptor blockers may be used as an alternative. Adverse effects, such as a persistent cough. Aspirin and/or antiplatelet therapy. Aspirin has been shown to decrease mortality and reinfarction rates. Administer aspirin immediately. Continue aspirin indefinitely. Clopidogrel may be used as an alternative. Resistance or allergy to aspirin. Administer a platelet glycoprotein, GP, IIB/Phi receptor antagonist. Continuing ischemia or with other high-risk features and to patients in whom a percutaneous coronary intervention, PCI, is planned. Eptifibatide and tirofiban are approved for this use. Oxiximab also can be used for 12 to 24 hours in patients with unstable angina or STEMI in whom a PCI is planned within the next 24 hours. Heparin, and other anticoagulant agents. Established role as an adjunctive agent in patients receiving TPA but not with streptokinase. Heparin is also indicated in patients undergoing primary angioplasty. Low molecular weight heparins, LMWHs, have been shown to be superior to UFHs in patients with unstable angina or STEMI. Reperfusion ST segment elevation, STEMI, or new bundle branch block on the 12-lead ECG. Presumed to have an occlusive thrombosis in an epicardial coronary artery. Candidates for immediate reperfusion. Thrombolytic therapy. Percutaneous coronary intervention. Bypass surgery. Improve survival rates. Thrombolytic therapy. Improve survival rates. If PCI capability is not available or will cause a delay greater than 90 minutes. Optimal approach is to administer thrombolytics within 12 hours of onset of symptoms. ST segment elevation. New left bundle branch block, LBBB. Or anterior ST depression consistent with posterior infarction. Tissue plasminogen activator, TPA, is superior to streptokinase. Recent trials show a high patency rate if a IIB/Phi receptor antagonist is combined with a half dose of a thrombolytic agent as the initial reperfusion strategy. Thrombolytic therapy. The effectiveness, highest in the first 2 hours. After 12 hours, the risk associated with thrombolytic therapy outweighs any benefit. Contraindicated: unstable angina and STEMI. And for the treatment of individuals with evidence of cardiogenic shock. Streptokinase, urokinase, and outplase, recombinant tissue plasminogen activator, RTPA, reteplase, tenecteplase. Surgical care. Percutaneous coronary intervention treatment of choice. STEMI, door to needle time of less than 90 minutes. PCI provides greater coronary patency, lower risk of bleeding, and instant knowledge about the extent of the underlying disease. The widespread use of stenting and adjunctive IIB/Phi therapy are improving the results of primary PCI. Primary PCI is also the treatment of choice in cardiogenic shock. Patients in whom thrombolysis failed. High risk of bleeding or contraindications to thrombolytic therapy. Emergent or urgent coronary artery graft bypass surgery is indicated. Angioplasty fails. Develop mechanical complications such as a VSD, LV, or papillary muscle rupture. Complications. Result: inflammation. Mechanical. Electrical abnormalities. Arrhythmias. Major cause of mortality in the first 24 hours. Ventricular tachycardia. Ventricular fibrillation. Complete heart block. Atrial fibrillation. Sinus bradycardia, congestive heart failure. Impaired cardiac contractility. Increased myocardial stiffness. Mechanical dysfunction, Mr. Cardiogenic shock. Hemodynamic state in which the heart cannot produce enough of a cardiac output to supply an adequate amount of oxygenated blood. 40% of ventricular mass has necrosed. Myocardial rupture. Most common 3 to 5 days after myocardial infarction. May occur. Ventricles. Septum. Papillary muscles. Atria. Ventricular aneurysm. Late complication. Left ventricle. Weeks to months after ME. Left ventricle. Mural thrombus. Ventricular arrhythmias. CHF, pericarditis. As a reaction to the damage of the heart muscle, 10 to 15%. Inflammatory cells are attracted. May reach out and affect the heart sac. Sharp pain, fever, pericardial friction rub, thromboembolism. Intracavitary thrombus formation. Result in infarction of peripheral organs. Brain. Kidneys. Peripheral vessel.